My assignment today is my experience, how I become wiser in selecting patient and making the right diagnosis. These are my disclosures. Over the years, hip arthroscopy has gained popularity, and the procedure is only as good as performing on the right patient. There was some questions back in 2011. I remember this article in the New York Times. This journalist called me and had some questions, and ended up in the front page of the New York Times. And there was some doubt about the procedures, so that put more emphasis on us to really have very good outcome on our patient, and most importantly, pick the right patient for the procedure.
The Yankees in both home runs and RBIs, and he takes that one to left field. Montañez going back. Can you believe this? Baseball theater. His first at bat, first pitch. A-Rod delivers a 3 RBI homer.
So these are example of success and injury pattern here. This is a skier. So traumatic injury. So these are patients that are very motivated, and given the right pathology, will have very good outcome. So we recently published in the JBJS a case example of a hockey player, an NHL hockey player. And the reason I'm putting that up is that this player came to see me initially 207 for right side hip pain. Came back 10 years later for a left hip pain. The left hip pain was after he had played many games in NHL. And what I like to show here is on the right side, when he came to see me, his joint space was good. We fixed him with an arthroscopic procedure, corrected the impingement, repaired the labrum. And you can see in 2017, 10 years later, correction of the bony impingement, repaired the labrum, stabilization of the condylolateral junction, good stabilization of the joint space. On the left side, no symptoms when he came to see me. Played, as I said, played many games in NHL. One of the most durable players in the NHL. Won the Stanley Cup at the end of his career. But you can see the progression of the joint space narrowing. Now, he had no symptoms. This was asymptomatic until he came to see me, and we corrected him. And again, as I said, we did the surgery on him despite the joint space narrowing. Did well, went back and played, and did very well at his return. But the reason I'm mentioning this is I think the importance of early intervention, because untreated impingement in a sport at risk or activity at risk can possibly lead to these situation when the cartilage deteriorate. And again, a surveillance system is something I've learned over the years in my patient who come to see me on one side, and we keep an eye on the left side based on their symptoms. So from 2000 to 2005, my treatment criteria included non-arthritic hip pain. I had a lot of athletes from rotational sports. They had a lot of power and pain with rotation, and a lot of them had contact sport, in addition to the rotational excessive forces. So usually when they came up with hip pain, labral injury was a big part of the algorithm for treatment. And this often was related to trauma, hypermobility, impingement dysplasia, and degeneration. Then, of course, in the algorithm, we look at condyle injury, capsule injury, extraarticular injury, and systemic issues. So picking the right patient in our mind, we had that mindset where we had to look at all these avenues to pick the right patient, have the right selection, and provide the right treatment. So 205 to 210, we got a little better in our diagnostic algorithm. FAI became more mainstream. And one thing I've learned is the Faber distance is very helpful to pick a successful patient for the intervention. The Faber distance test representing a captured hip, not necessarily the bony impingement restriction, but this Faber distance test correlates with a captured hip, tight periarticular musculature. And usually this patient with the captured hip or reflection intra-articular synovitis related to intra-articular pathology. And usually for us, these patients, when they have the Faber distance asymmetry, have a very good outcome after treatment. We've been collecting data, and I've learned that collecting data, analyzing your data on your patients can lead to best treatment and help provide best treatment for our patients. So I've been collecting this on all my patients since 2005. Also, we execute on changes based on what we've learned. So this is an article that we published in 2009 where we found that prehab before surgery can improve the pre-op modified iris hip score, and having a better hip score to start with lead to better outcome. We also learned from that analysis that 2 millimeter or less of joint space is, quote, a relative contraindication to the procedure because of the condyle changes. And then preserving the labrum was found to be important. So we learn and then we execute and make some changes based on what we find to optimize the treatment of our patient. Also, technically, this is a difficult procedure. Hip arthroscopy definitely is a technical procedure. So understanding how to place our anchors, we studied that, how much rim to resect. These are things we've learned and pearls that helps us provide and deliver better surgical intervention to our patient. What about the capsule? We know now capsule is mainstream. Preserving the capsule is important. You can see here a patient with a stretched anterior capsule, iliofemoral ligament elongation, right to left. Right obviously has no resistant exhaltation. The patient has normal rotation of her femur. So clearly this was a situation where the capsule was lax. And again, the lug roll tests help us make the diagnosis before surgery. The seal, axial distraction tests. I like sometime to really know before I go in what kind of seal we have. The axial distraction test with ultrasound is very helpful. And we're in the process of validating that test. I've had NFL football player coming to see me after surgeries at other centers. They come to see me. The patient develop adhesions. They have an incommodate labrum, and the axial distraction test really is helpful in preparing for the procedure. So this is another pearl I've learned over the years. Also, we found that our 10-year outcome further refined our indication, and biomechanics supports our treatment algorithm. And now we've evolved, and Biologic has been added to treatments. This is a paper we published in JBJS American, Survivorship and Outcome at 10 years following hip arthroscopy for FAI. In that paper, we found that the patient at 10 years with the right indication had very good outcome. The median patient satisfaction at 10 years was 10 out of 10 in this group. And, you know, we found that after analyzing the data, you know, we had better refinement of our indication. Joint space, again, less than 2 was a relative contraindication. And age at surgery appears to be a factor as well in this cohort. So when we adjusted for microfracture, labral repair was superior to labral debridement. You can see the graph there. Joint space greater than 2. No acetabular microfracture, very good outcome. Joint space less than 2. You can see that deterioration over the years. Joint space greater 2 with microfracture, again, good survivorship. But if we have less than 2 millimeter joint space with acetabular fracture, you can see the drop at 5 years. So by age, you can see the survivorship. Younger patient had better outcome at longer survival curve by age at 35 versus those who were older at 10 years. So we also look at labral reconstruction, and I look at the first 100 segmental labral recon compared to the most recent. And what we found again in that paper is that we updated our patient selection criteria. There was lower rate of conversion to total hip. The outcome were similar, but the group 2 showed maybe better outcome at 4 years. Also, we found that younger age and joint space narrowing, again, we execute on our endpoint criteria to use for execution and selecting the best patient for the procedure. We also develop a tool to predict outcome. This is a paper in JSM with Dr. Libis from our group. And again, this is a tool for post-operative hip outcome score, ADL. So again, we look at age at surgery, sex, previous surgery, chronicity, alpha angle, center edge angle, joint space less than 2, baseline Huss ADL. And based on that, we execute on our predicting outcome tool. Also, this is another good paper that we published recently looking at a predictive model for severe cartilage damage. We use patient-specific data collected on every patient, and then we look at 2,396 hip arthroscopies. And again, this helps predict severe damage on the femoral head on acetabulum before going into surgery. That might change your decision process based on this model. So patient selection is the key. Positive findings on physical exam, both static and dynamic. As I said, I really believe in analyzing the captured hip, picking those up, doing a sports test, a dynamic examination. Of course, we look at the MRI, the x-rays, and then we want to make sure that the patient has good muscle balance. So we look at the conserved treatment also before surgery, just to make sure that they have appropriate strain. And also we want to make sure that when we select our patient, they're willing to comply with the rehab. And then important also, even if they come to see us for hip problem, you got to keep in mind there might be other issues associated with the impingement, the instability, such as core muscle injury, low back problems, and other intra-abdominal problem. So does age make a difference? Again, we publish on the outcome in FAI patient 50 and older. Survivorship was 90% in patient with greater than 2 millimeter joint space, and 57% with those in less than 2. Also, we look at joint space predicting total hip after hip scope in patient 50 and older. We found again that joint space of 2 or less millimeters or less, 81 patient converted. scalar log range 73%, and tonus grade 65%. And this early point, joint space measurement were the most accurate predictor of total hip and should be used, in our opinion, to educate the patient for the risk of early failure for hip arthroscopy. So an ideal case, intra-articular injury pattern, pincer deformity, cam, labral tear, no signs on the coverage, younger patient, repairable labral tear. Of course, understanding the cause of the tear, pincer, small cam, and sometime if there's significant on the coverage, like in this plastic patient, we now proceed with combined procedure with Dr. Mata at our center here, and we address the other coverage as well. And this is something that's been very successful in our hands, a combined procedure, hip scope first, correcting the labral pathology, addressing the cam if necessary, and then having Dr. Mata perform the PAO for the coverage. So again, joint space gradient to implants. There's multiple muscles around the hip, 27 musculotendinous junction. We want to make sure that prior to procedure, there's good optimal balance between the muscles. Sometimes it's not possible because there's pain inhibition for attempt at getting strain on these muscles, but we try to optimize the abductor, adductors, flexor extensors, and also limited issue of changes is important. And you want a patient that's compliant with the rehab protocol after surgery, because rehab is important after surgery, obviously, as we know, to optimize the outcome. So what I've learned is obviously picking the right patient is important. Have a good physical exam so you understand what you're treating. And what I mean by that is we believe a good dynamic exam as well as understanding the rotation, movement, the hip position at risk, and again, understanding if the hip is captured or not from the intra-articular pathology is important. And utilizing the technique, be prepared to execute on the technique you've learned. And again, we have more advanced technique and a lot of technique available now to provide the patient adequate correction of the pathology. And collecting your data for your own outcome, I think, is important. I think we learn a lot from following our patient closely. And I continue to learn from my patients, from our fellows. And obviously, you want to provide the best outcome possible to your patient every time. And this is a paper that was published this year, Best Practice Guidelines for Hip Arthroscopy in FAI. So this was the Delphi process. Again, a panel of experts in the field look at preoperative, intraoperative, and post-operative guidelines. And these are just, I think, important thing to read, keeping up with the literature, and this again provide guidance and guidelines for patient selection. So this was published in the Journal of the American Academy of Orthopedic Surgeon, and I think it's a good guidelines and good advice for our patient selection. So in summary, hip arthroscopy is not for every patient. Patient selection is key to successful outcome. Common indication and contraindication have been learned through analyzing our patient outcomes. And one thing I've learned also, when you develop a new technique or you think you have something that will help your patient more, it's very important to prove it and validate your technique with patient outcomes. And again, we look at our 10-year follow-up on labral repair, debridement outcomes, and also labral recon recently. And this is very helpful because we understand very well how our patient progress and if the treatment provided to them is optimal, again, to provide them with the best possible outcome. So again, medicine, orthopedic surgery is an art and a science. We want to practice evidence-based medicine to really optimize the treatment for our patient. Thank you very much. I hope this talk has been helpful.